Very good evening, everyone. Myself, Dr. Venkatesh Karthikeyan from AIIMS Patna. Our study is on the topic Stakeholder Analysis for Hypertension Management in the context of the Indian public health system. As we know, hypertension is the leading risk factor for cardiovascular diseases and the topmost cause of mortality. Around 1.3 billion adults across the globe have hypertension, and about two-thirds of them reside in low LMICs like India. In our country, about 1 in 4 adults have hypertension. But despite that, only a minority of them receive treatment, and 88% of those who receive treatment fail to achieve optimal blood pressure control. To tackle this burning issue, SDG 3.4 target has been set, which is to reduce the mortality from NCDs like hypertension. Also, India has set a goal to have a relative reduction in the prevalence of hypertension by 25% within the year 2025. Understanding the magnitude of the problem and to achieve the targets, Government of India has started thinking in this direction and has launched the NPCDCS. As we know, hypertension management is not a game by a single stakeholder. Rather, it requires support of multiple stakeholders at multiple levels. So, along with mapping the stakeholders, identifying the enablers and barriers is also essential for successful program implementation and stakeholder engagement. In India, not much literature is available on this, despite this being a major public health concern. Hence, we took forward the study to identify and categorize the key stakeholders involved in hypertension management, to assess the interplay of perceived power, position, and interest of various stakeholders, and to determine the enablers and barriers to successful engagement of various stakeholders. So, who to find out who are the key stakeholders, what are their stakes, how do they engage, who is the key person. To answer all this, we adopted an exploratory descriptive design of which scoping review was a part. We identify the key stakeholder constituencies and categorize them. Our team developed operational definitions to appraise the stakeholder roles in terms of power, position, and interest, and possible enablers and barriers experienced by each of them from the available literature and through iterative consensus building discussion. This served as our conceptual framework, which was further validated by representatives from stakeholder constituencies through scoring. These are the operational definitions which our team used. So we have listed all the stakeholders and categorized them into five, namely policymakers and program managers, development partners and civil society organizers, academia and research stakeholders, healthcare providers, and beneficiary stakeholders. The identified stakeholder category are now mapped against the WHO Health System Building Blocks framework to understand the various stakeholders, their enablers, and barriers to effective engagement of stakeholders and program implementation. This might seem like an empty table. Rather, this is a heat map which was prepared to indicate the relative stakes of the constituencies across the WHO Health System Building Blocks framework based on the available literature and through iterative consensus building discussion among the authors. A graded color-coded representation was used to indicate the stakes. So darker the green, the higher the stakes. We use the scoring method to assess the stakeholder representatives' perception of the power, position, and interest of various stakeholders in hypertension management. We formulated a score-based template, and it was administered to 17 experts who did the scoring. The experts were asked to score in such a way that the aggregated sum of power across the five stakeholder categories is 100. Similarly, the total of position across five categories and interest, this total of interest is 100. Similarly, another score-based template was administered to the experts, and they were asked to score in such a way that the sum of enablers across all the six blocks is 100, and the sum of barriers across the six blocks is 100. So coming to the results, we observe that the stakeholder representatives considered policymakers and development partners to have the highest power. That is, they have the highest potential to implement the to affect the policy implementation. They also considered beneficiaries to have the lowest power. Experts consider policymakers to have the highest position, which means they support the policy implementation the most. And they also consider policymakers and program managers to have the highest interest, which means they considered policy implementation as relevant and consider them to have highest interest. This was closely followed by development partners, academia and research stakeholders, and beneficiaries in a close fashion. Similarly, the results of enablers and barriers show that service delivery emerged as a top enabler as well as a top barrier. Uh, our study showed that leadership and governance emerged as a critical enabler and health workforce emerged as a critical barrier. The scores received were reviewed by the authors team to reflect upon the contextual interaction between the enablers and barriers and the potential role of stakeholders. This was done with a team of authors and two extramural experts. The synthesis was done using a pragmatic lens while considering the scores obtained, the evidence available from the literature, an understanding of the Indian public health ecosystem, and heterogeneous context of health service delivery in India. So coming to discussion, the National Multisectoral Action Plan was released by the Ministry of Health and Family Welfare, and it highlights the concern that everyone thinks it's a role of Ministry of Health and Family Welfare to address the hypertension despite it being a public health problem. Our study also shows that everyone considered policymakers to have the highest power, position, and interest, which is in agreement with the concern highlighted by the National Multisectoral Action Plan. Hence, we must change this attitude that it's not only the role of Ministry of Health and Family Welfare, rather it is the role of multiple stakeholders in order to successfully implement the program and engage the various stakeholders. Our study shows that the beneficiaries are perceived to have the lowest power and position despite having fair levels of interest. This clearly shows that there is a gap between the policymakers and the patients, which should be bridged by involving patients in important decision making related to hypertension. Our study, similar to other LMIC studies, shows that service delivery emerged as a leading barrier. But the difference is that service delivery also emerged as to be a leading enabler as well. Hence, we can consider service delivery to be an obligatory pivot for optimizing health system performance. There's inconsistency and heterogeneity in the service delivery. Hence, we must standardize it, and we should have set quality mechanisms, written SOPs and protocols so that service delivery is optimized. Besides service delivery, leadership and governance emerge as a top enabler. This was rather logical because for service to be offered at this massive scale, leadership and governance are of paramount importance, and hence the role of central and state governments and program administration are very crucial. And similar to other studies from different LMICs, our study also showed that health workforce was the major barrier in hypertension management. Hence, the policymakers who have the highest power, push, and interest should take adequate steps to manage hypertension, to train the health workforce, and to motivate them for better hypertension management. The strength of our study lies in its hybrid approach. The context of hypertension is rapidly evolving, and so is the role of stakeholders. So, to address this dynamicity, we use a hybrid approach that leverages the standard practices of review of available literature and stakeholder consultation, as well as an iterative consensus building mechanism using a multi expertise team of co authors to triangulate the information and synthesize the interpretation. Our analysis is context driven, but at the same time runs the risk of being non exhaustive and transitionary. Hence, we call for a deeper exploration of the situation and suggest this as a topic for further research going forward. So, coming to the conclusion, to bring about impactful efficiency in the health system for hypertension management, provider-side intervention, especially at the point of delivery, emerges as the need of hour. Policymakers and program managers could lead using a top-down leadership approach and focus on deploying adequately trained and motivated health workforce to deliver the hypertension services. For ensuring better performance of the health system for hypertension care, the service delivery seemed to be the obligatory pivot, and health providers could serve as the point of convergence for the efforts made by all the stakeholder constituencies. These are the references. Thank you.